Good morning, good afternoon, good evening, and good night, everybody. Thank you so much for joining us to this today webinar. Today is September 16, 2020. My name is Dr. Dina Ziadlu. I am a chair of Digital Transformation Leadership Working Group at International Society for Telemedicine and Electronic Health. We have a great pleasure today to have a fruitful webinar for you. And thank you for joining us. We have Dr. Emmanuel Abara from Canada and Dr. Anthony Sanjay from Australia, my dear vice chairs in the Digital Transformation Leadership Working Group. And we have Dr. Adolfo Sprangberg from Brazil. He's gonna open the session with a brief introduction about our International Society for Telemedicine and Electronic Health. And after that, we start our presentation for you. Dr. Adolfo, please.
Yes, please. Thank you very much, Dr. Dina. It's my great pleasure to participate of this session. So, dear colleagues, distinguished speakers, partners, and ISfTeH affiliated members. So, I should say good morning, good afternoon, and good evening to all of you, because we have people attending this session like us from different parts of the world. So, on behalf of the ISfTeH, I welcome all of you to this webinar organized by the Digital Transformation Leadership Working Group in conjunction with the ISfTeH Executive Secretariat and the Working Groups Committee. So today's session will be about the theme Innovation, Decision Making, and Improvement in Digital Health. Just a second, please. I'm just putting my image here and okay, so the first slide is okay. Okay, before going the outstanding topics of the presentations, I need to say some brief words about the International Society for Telemedicine, mainly directed to the audience that is not yet familiar to the ISfTeH. So the second slide, as you can see, our society is an NGO and non-for-profit organization in official relations to the World Health Organization that founded in 1997, exactly 23 years ago in Japan. The headquarters of the ISfTeH is located in Basel, Switzerland, and the mission of our society is mainly to facilitate the international dissemination of knowledge and experience in telemedicine and e-health. Next slide, please, Dina. Next, please. Next slide, please. Currently, the International Society for Telemedicine and e-health has affiliated members from over 100 countries in all continents, distributed in different membership categories. So like national members, corporate, startup, institutions, associations, nurses, and students. So the society counts on the support of several working groups, as you can see in this slide. The working groups are in fact a very important segment of the ISfTeH, composed by colleagues that are responsible for organizing practical activities throughout the year. So webinars like this one represent an important segment of these initiatives, mainly in current pandemic periods. So next, please. In this year, there is something new. Next slide, please. Something new available on the main page of the ISfTeH website. We talk exactly of a specific chapter dedicated to the theme of COVID-19. This is an important area through which ISfTeH members and partners can share their information, experiences, and solutions concerning the COVID-19 pandemic. So a lot of updated information is currently available. Next, please. Other important activities. organized by the ISfTH and provided for the affiliated members include the newsletter through its quarterly edition. Yeah. And the journal of the ISfTH. So the journal is coordinated by Dr. and Professor Maurice Mars, Richard Scott, and Malina Jordanova. So affiliated members are invited to participate through both initiatives, the newsletter and the journal. Next, please. So those interested in joining the ISfTH can affiliate through different membership categories. Now you can see the slide showing the different categories for affiliation. So you are all welcome, and it's important to say that the students up to MSc and 35 years old and nurses are free of charge membership categories. So the next, please. Requesting affiliation is really a quite easy and simple process. Just visit the ISfTH, yeah, exactly. Just visit the ISfTH website and go directly to the how to join area. And finally, the next slide, please. This is the address of the ISfTH website. It's really worth a visit. The ISfTH looks forward to welcoming all of you as new affiliated members. So thank you very much for your attention. I wish you all a very nice session. And now I'm very pleased to invite again Dr. Dina Ziadlu, coordinator of the DTL working group, so she can start the webinar. Dr. Dina, please. Thank you very much.
Thank you so much, Dr. Alfredo, for introduction. And I would like to express my gratitude to ISfTH board member for their support, and also the digital transformation DTL members that always their support and their ideas and opinion would be great for improvement of our DTL system and services all over the world. So today I want to start my presentation with the title of Role of Innovation in Health Transformation, Healthcare Transformation. So at this point, I would like to just mention a few tips here. The focus of this presentation today is on micro level, because we have different types of innovation, different levels of innovation. We have an innovation in technological side, in organizational and managerial side, and also social innovation and global innovation. But at this presentation, I'm going to just focus on hospitals and medical centers innovation that we can provide or develop in our centers. And the first step that we need to have for this point is to create a shared definition for our healthcare organization. What is the exact definition of innovation for their organizational and managerial innovation? And then I'm going to talk about the healthcare ecosystem needs and gaps that we have in innovation, current status, and how we can apply for ongoing improvement and institutionalize the innovation in our healthcare organization. So first, for being in a same road, so I just provide the brief explanation about the innovation. What is the innovation? It can be an umbrella concept for generation, diffusion, and adoption of an idea, process, good technology, or model in our healthcare organization. It can be an integration of a new concept, invention of a new device technology, or development of a new market. And one of the description that I really like is about the innovation is process of turning opportunities to new ideas and putting these ideas into practice. Likewise, we have a different classifications, and scientists, the experts provide different types of innovations. But one of the one that I really like talk about it today is about the innovation based on the TED and Besant's classification, which is called 4Ps. We have four types of innovation: product innovation, process innovation, position innovation, and paradigm innovation. In product innovation, we are going to repositioning or improving a product, good, or service. For instance, in a healthcare organization, we have different types of the technology that we are using in our system, from artificial intelligence, blockchain, Internet of Things. So we have innovation in products. For instance, in the past, we save our medical records on magnetic tapes, but now we have a PAC system, we have an iCloud, so we can use this innovation to storage our medical records on an iCloud. We have a process innovation. In process innovation, we are looking to optimize the patient care through improving a process. With this way, we want to have a better service or product to deliver the consumers. One of the clear example of this process innovation is switching from paper-based systems to the paperless systems. We have a teleradiology or radiology information system, pharmacy information system, laboratory information system, and all the patient health records goes to these services, and we can have the comprehensive processing innovation at this part. Likewise, we have a position innovation. At this point in position innovation, we are going to improve the perception of user by changing the contents of the product or service. This is kind of consumer focused, because we are going to engage the patient, for instance, in our services. We are going to shift their perception that doctor will assist them, not direct them. It is kind of patient engagement philosophy that we have in healthcare. Or another example that I can provide for you is about providing the high quality service for the patients to enhance their satisfaction. So in position innovation, so we can have a different types of innovation. For instance, Chicago has a children's hospital through building a technology with the name of Premi application. They are using this Premi application for improving the satisfaction of the parents who cannot stay in a hospital for 24/7 for their premature babies. So they can use this application and track and monitor their baby's health, and also communicate with the healthcare team 24/7. This is part of the position innovation that we are trying to create high quality and enhance the satisfaction of the patients and build the excellent reputation for our hospital or medical center. Another type of innovation that we have is paradigm innovation. It is about a change in mental models that frame the concept of organization toward understanding what makes better development. This strategy would be a great one for the medical center, because at this point, this is not focused on technology development, technology implementation, or process improvement. It is all about how we can make a better environment for our healthcare, how we can make a better human-based services for our organization. For instance, an example of paradigm innovation is redefining hierarchy organization to holacracy organization. It's going to be a great innovation in our healthcare if we can decentralize power and empower employees and involve the physicians, nurses, and other employees in our decision making to increase the joyfulness and happiness for them. It is kind of evolution of business models for us. So For this aim, we want to have a comprehensive environment, healthcare environment, dynamic healthcare environment. For this aim, we need to understand why we need to have a healthcare ecosystem rather than healthcare system. Because a healthcare ecosystem, as you can see in this model, we have a different stakeholders in our healthcare. From pharmaceutical companies, regulators, government, patients, hospital and healthcare networks, insurance companies, technology companies, life science companies, academia, supplier, virtual care. We have a different types of stakeholders, and these stakeholders must be in a healthcare ecosystem. What is the healthcare ecosystem? It's as a set of capabilities and services that integrate value chain participants. Indeed, it is a pool of stakeholders with potential to deliver a personalized and integrated experience to the customers, which are our patients. So through this ecosystem, we can enhance productivity, engage people, and improve outcomes. Therefore, in innovation, we have to consider our healthcare system as a healthcare ecosystem that create a comprehensive, interconnected stakeholders who are connected, collaborated, and have a great relationship with each other to provide a comprehensive service toward achieving the quadruple aim of the healthcare. So because of that, we need to build these concepts in our healthcare to embrace patient engagement, self-care, virtual care, remote care, social and community care, and also financial support for our system. The next thing that we need to consider in our managerial innovation is about needs and gaps that we have, because we need to understand what is the gaps that we have. We don't want to jump to establish lots of digital technologies in our system. We need to understand what is our need, what is our requirement, and based on that requirement, we start to planning the strategies, start to implement the services for our system. Here is some obstacles. So if you see this part, so we have different types of obstacles in our organizations to develop the digital technology. For instance, we have a technologies issues, management issues, organization issues, or environmental issues. So I classified this information here for you in 4 parts. For instance, in technology side, we have a high cost of technology development. We have some concentration for the research and development of the technologies. There is a gap between tech industries and healthcare users and hospitals, which is one of the most important parts. And we need to consider it in part of our innovation. If we want to have innovation in our healthcare, it is important to connect the tech industries with the healthcare organization, with the hospital and medical centers, and navigate our needs and align our need with their inventions. Another one is the lack of information in value creation of the technology. We have issues in supply chain. So these are the hints that we can work on it for developing our innovation in healthcare. Because when we know what are the gaps, so we can understand them, and based on that, we can innovate the better processes, better position, better paradigm or products for our system. And also in the technology side, we have a privacy and confidentiality issues, and this part can be one of the most important parts to consider in our innovation strategies. In a management part, for instance, we have a cultural issue in healthcare, which is method-based and risk evidence-based. So we still have a fear of uncertainty in technology use. So in a COVID surge, we have experience for using the telemedicine technologies, and we got some feedback from the patients. They couldn't trust the technology yet. So these are important, how we can build our technology, how we can build our society or our patients or our physician and system to have a best trustable system. So these are part of the complex regulation that we have. So we have a strict regulations in our system in the United States. So the many doctors have a fear of the uncertainty to use the telemedicine services, to use the mobile health services for their patients, and um, there are some lawsuit or something like that we have that we need to consider them. Moreover, we have a lack of actionable strategy for innovation management. For instance, one part of these actionable strategies can be crisis prevention rather than crisis management. Before crisis happens, that would be great if we can develop some strategies for crisis prevention. It is another part that we think about it for in our managerial innovation. Moreover, there are some political barriers, public policy barriers, and complexity of reimbursement in our healthcare system that must be considered. In organizational side, as I mentioned earlier, we need to build a healthcare ecosystem. So because of that, we need to have a good communication and relationship between the government, public sector, and private sectors. And the rigid budget and unaligned budget between the capital budget and operation budget is another part of the organizational barrier that we have to boost our innovation. Lack of plan to adopt and generate new behavior, or lack of a shared definition about the innovations are part of these issues that we have in our medical centers and hospitals that need to be considered. In an environmental side, so if you see here, so we have to consider this part in our managerial innovation, in our innovation part, because the environment of the healthcare is one of the most important part that we need to consider about it. It is not just about technology development or management innovation. It is about the whole system. In a whole system, we have an environment, and the lack of environmental sustainability policy sometimes would create a big and huge issues in our healthcare. Per WHO, every year an estimated 16 billion injections are administered worldwide, but not all of the needles and syringe are properly disposed of afterwards. So this is important because this is part of the our public health, and we need to consider these environmental issues that we have. And when we consider these environmental issues, so we can have a better mindset to develop the innovation services and invent some solution for our environmental barrier and issues. And also we have a lack of a clear map to illustrate the leading factors of healthcare on environmental issues. For instance, if we can create some bridge between the healthcare and environmental issues. For instance, when we are talking about climate change, we must provide some educational plan for the people, how the climate change has related to the healthcare system, how it can impact on respiratory diseases, and how we can create some innovative tips for our healthcare, innovative initiatives to improve our climate change through our healthcare organizations. And what is the current status that we have? There are many different types of innovation in the United States. For instance, we have, according to McKinsey, in 2019, we have more than 580 healthcare technologies in the United States. And the value of these technologies over than $830 billion, which is a considerable amount that they are focusing on patient engagement, new care model, data, and analytics. We have to manage these technologies, but beside this technology management, we need to have some innovation improvements in our system. For instance, in healthcare market, we have 52% on body devices, 33% patient monitoring, 30% in body device, 30% diagnostic equipment, 30% pharmaceutical equipment, and 25% environmental monitoring, 25% patent compliance tracking, and lastly 22% 3D printer and connected parts. We have a huge pool of digital health technologies in our healthcare environment. But the important part is how we are going to manage this part, how we can balance this part with managerial innovation, organizational innovation, and our environmental innovation. These are really important to understand how we can do it. To do so, for instance, the Center for Medicare and Medicare, CMS and ONC collaborated together and create some programs for interoperability of the data sharing for the EHR around all states of the United States. They are developing some preventive medicine programs and personalized medicine to manage all these digital technologies search. One of the examples that I can provide for you is about the Mercy Virtual Hospital, which is one of the first hospital in the world, which is a virtual hospital, no-bed hospital. They provide telemedicine programs for their communities to deliver the advanced model of care for the system, which was part of the technological innovation. Pennsylvania Hospital, for creating environmental innovation, they switched from hospital as a sterile environment to hospital as a hoteling environment. Another example is Boston Children's Hospital. They use 3D printing to test the innovative practice before the surgery. They can improve the performance of surgeons during the surgery by this kind of innovation in their healthcare organization. Another example is about the University of Chicago Medical Center. They use the artificial intelligence algorithm to develop a predictive analysis, and they can improve the workflow of the operation room team, which was part of the process innovation that they applied in their system. There are many types of examples for actually the healthcare organization that we can study and apply it as a best practice in our innovation, managerial innovation. And one of the most important part that I mentioned earlier, it was about the collaboration between the startup companies, high technologies companies with the medical centers. For instance, at this point, we have a Stanford Medical Center that partnered with the Apple company to launch the largest ever digital health study. They used the Apple Watch to check the heart disease. And it was a successful project that they had, and it was part of the union between the startup companies, the high-tech companies, and medical centers. Another three examples that I have here for you, it's about the human-centered factors that we must consider in our innovation. For instance, in a nursing center, they use the nursing transformation center to improve the practice environments, to engage the nurses in a moral environment to improve their satisfaction and productivity during the change. Another example was about optimization of the care system and process by applying the human behavior factors that MedStart Institute applied as an innovative way to optimize their performance of their employees. And also, John Hopkins has a great strategy for transforming the care based on the human-centered design. So they has a strategy with the name of LEAD, listen, image, and do, which means that they believe if we want to have a best innovation in our healthcare organization, we need to consider the human-centered design. We need to listen them, imagine whatever that we want to create a shared vision and do and act for achieving that desired future that we want. The last steps that we have in applying in actually innovation development is first we have to develop ongoing improvement, and then we have to institutionalize our innovation in the system. For this aim, there is a cycle of the key factors for increasing the effectiveness of the innovation. First of all, we have to balance between the technological, managerial, organizational, and environmental innovation. We have to invest on establishing future-based organization. What is the future-based organization? The organization that work on analytical services to see what is the future of the healthcare, how they can horizon scan of the future of the healthcare to build their presence. So these organizations are global oriented, that align their local strategies based on the global change, based on the global benefits. These are the future-based organization, and they are attempting to create a mature health ecosystem for themselves. Another step is providing a shared definition. As I mentioned earlier, it is important to understand what is the shared definition for our employees, how we are communicating with employees this definition of innovation. And then we must to prioritize the innovation in our healthcare organization to understand what is the gap, what is the need. We have to collect, filter, align, validate, approve, and then implement our innovation based on these priorities. The next step is going to be the opportunity creation to minimize the risk and waste, measure innovation, and enhance experiment with new idea. It is important to be open for the new ideas in our healthcare. Understand what is the idea of other employees, physicians, nurses, engineers, and how they can make a decision or make a difference in our healthcare system. And also, we have to support the human resource and develop some incentive, rewards, and talents for these innovative mindsets. Likewise, we must to make an alliance among the hospital and the startup. As I mentioned earlier, we have to institutionalize sustainable innovation and mature healthcare ecosystem. Invest on not technological innovation, but also we must to understand what are the organizational innovation, managerial innovation, environmental innovation that we can have in our healthcare system. Then we can go through the establishment of the innovation-driven environments. and create the culture of innovation and nurture the world-class the skill sets. And of course, at this road, we need to understand who's going to be the agent of change, agent of transformation, or innovation leaders in our healthcare. Because for any activities, we need to understand uh, who's going to be the best talent for our healthcare system. So this presentation was a brief presentation about the managerial innovation with different aspects and side of the this managerial innovation with other innovations type. So I just wrap up my presentation and handle my presentation to the Dr. Anthony Sanjay from Australia. So Dr. Anthony, please start your presentation.
Thank you, Dina. Great presentation on managerial innovation. So now I'll continue and discuss on transforming healthcare through decision support systems and virtual care. Can you please move back the slides, 2 slides back? Thank you. Yep, thank you. So today I'll be talking about introducing wicked problems we have in healthcare, and certainly further emphasized due to COVID-19, an introduction to applications of artificial intelligence in health and decision support systems, and what future implications this might have for us. So since the start of COVID-19, yep, thank you. We can see that healthcare is divided into two. One, the rise of COVID cases has resulted in more beds being formed in emergency hospitals like the one on the left in New York. Well, at the same time, what's often forgotten is that outpatient clinics are being closed, and patients with chronic diseases, heart disease, diabetes, which requires routine care, are not receiving them. And this certainly emphasizes the problems we have in health, that medicine is inherently complex. It certainly brings huge potential for mistakes. Clinicians have limited time. A visit will only last at most for 15 minutes in many cases, including administrative tasks. Combine this with the limited resources we have in health, which are often imbalanced, resulting in while an underdiagnosis of diseases and unequitable access to health, we certainly need a solution that's different from what we're doing every day. Could you please, yep, thank you.
You have
so healthcare
screen, Anthony, you have a full access to controlling your screen, so I don't have access to your screen.
Right, so, okay. So maybe it's just the intercontinental lag. So sorry about that for every viewer. So healthcare and technology has certainly gone a long distance from the early 19th century, which is called the Health 1.0, where we focus on evidence-based medicine with a focus on survival. So just a moment. yes, with a focus on survival, followed by Health 2.0, where we start thinking about value chains, about end-to-end service coverage, and the start of many big health systems, especially in the US. Then we move to automation, where cost efficiencies become the norm, to digitalization, where we're currently at, which resulted in the formation of many new business models, health-based apps we find today. And we're moving towards Health 5.0, where there's personalized medicine, more customer focus, and lifelong partnerships. And this is where decision support systems in 4.0 and 5.0 can play an important role if done right. Right. So decision support systems, I'll just stop for a moment. Full screen. I'll just share it from here. Sorry about that to everyone. So decision support systems, so clinical decision support systems provides clinicians, staff, patients, and individuals with knowledge and person-specific information, and importantly, intelligently filtered or presented at appropriate times to enhance health and healthcare. And there's many that has come. For example, the most recent one, which utilizes artificial intelligence, is for diabetic retinopathy, as we shall see later. But before that, the first one approved by FDA was in 2014, a LifeCore for detection of atrial fibrillation. And this certainly started a long time ago, and it's not a recent event. Since 1315, humans, we would say, Raymond Lull in Ars Magna has showed and has mentioned that reasoning might be artificially implemented in a machine, which forms the basis of AI today. So we shall now see the use cases for decision support systems and how it might improve health for respiratory, cardiology, and diabetic retinopathy. In respiratory care, pulmonary function testing or spirometry plays a very important role. And high quality testing will result in improved management of many chronic respiratory disorders. But an issue is the quality is often low in practice. But what CDSS can do and help is it can help triage patients that require expert advice and not. And in a small validation study, we can see here that online classification by CDSS can result in 96% sensitivity and 95% specificity. But importantly, I think for the digital transformation perspective is that it reduces the number of tests that requires offline remote classification to only 11%. In cardiology, multi-center studies have showed that using ECG and without the need for echocardiography, which is limited in many places, we can obtain scores which predicts development of heart failure with reduced ejection fraction, with quite a high specificity and predictive value. Another aspect is the use of CDSS for mass screening in diabetic retinopathy. It has become the first AI-based device approved by the FDA. So the device itself is like a normal fundus camera, which sees and takes a picture of your retina, as we can see on the right. But what it did further is through deep learning technologies, It can analyze the picture, resulting in a recommendation in the exam results and further recommendations on when retesting is to be done. But we should always remember, and I think I would like to emphasize here, as Dina also discussed in the previous talk, that full automation does not always mean cost effectiveness, and it might not always be the answer. AI does have limits, and if we see here, for example, for diabetic retinopathy, an economic analysis and modeling in Singapore did show that semi-automated screening actually was less expensive compared to the fully automated model. Even so, policy support for CDSS is growing. For example, in US, the American College of Radiology from 31st December 2021 will mandate all advanced diagnostic imaging testing for Medicare patients to be documented via a CMS qualified clinical decision support mechanism. If not, it won't be paid. So this is certainly a bigger push compared to the previous model where the use of CDSS is in a way recommended for and to be integrated with workflows, but is not as prescriptive. Even so, current questions in digital health research remains abundant. Importantly, from the research side of things, validation of an algorithm with data sets is not evidence of clinical efficacy. As leaders who decide which systems to implement, we need to always remember that medicine is inherently complex and is not always defined by what's in the electronic health record. There remains a need to see and prove improvement in routine clinical outcomes and quality of life. Prediction models need to be implemented with care. We should remember that prediction of risks for adverse outcomes can take place, but if there is no treatment, then that's certainly of no utility. On the other hand, screening more might result in overdiagnosis and overprescribing, and behavioral factors and clinician inertia remains things we need to consider as well. So question everyone often asks is digital health taking over our future? And I think the answer is, as long as we develop AIs based on human needs and values, it will not. But AIs does have, and decision support systems does have a role to play. Supervised machine learning is good for routine tasks. It helps us see things we cannot see. And importantly, it helps us bring explainability when possible to things we cannot see. Although not all that can be done should be done, and we should always remember who will be liable when things go wrong, especially in health. But there's much rewards to be gained if decision support works correctly. We can develop learning health systems easier than before with big data, infrastructure advances, and data integration, making data to knowledge, knowledge to improve performance, and evaluating performance to generate new data even faster than ever before. And when combined with virtual care, there's even more that can be gained. And hopefully, I envision in future, we'll have hospitals move not from buildings, but to communities, aged care, chronic care, palliative care, and all other forms of care at home, which is already beginning even now in many places like New Zealand. But we should always remember, and certainly the hope is, health technologies is not the end goal. The end goal is a more accessible health, more efficient health system, cheaper, but improving and bringing better health outcomes. Thank you, and I'm very much happy to hear from you.
Thank you very much, Dr. Anthony. So I would like to have Dr. Emmanuel for our next presentation. Dr. Emmanuel, would you please start your presentation? Dr. Emmanuel? Dr. Emmanuel? Dr. Ibarra, do you have my voice? Oh, it seems that we lost Dr. Ibarra here in the presentation. Just give me a minute to see what's going on over there. Dr. Ibarra? Hello? Dr. Ibarra? Okay, we have Dr. Ibarra on line. So Dr. Ibarra, please introduce yourself and start your presentation. Thank you so much.
Well, sorry, thank you very much for having me on this webinar. And I believe my colleagues have, can you hear me clearly?
Yes.
All right. So my, my background has been, I'm a rural physician, and I'm interested in the affairs of the rural and remote communities. So for the next 10 minutes or so, because our time has gone, I'm going to share some ideas of how we can use telemedicine, telehealth, virtual care, they're all the same thing, to disrupt inequities in rural and remote communities. Now, are you going to help me with the slides, or I have to adjust it? Request remote control. I do not have any conflict of interest to declare. I work in the community. Next slide. Nina, can you help me with the next slide?
Sure, of course.
So virtual care or healthcare are three components. There is the people, there is the location, and there is technology. And when these combine together, we have good access, good quality, and cost-effective care. As you know, telemedicine has been in existence for over 50 years. But today, COVID has made it center stage. Next slide, please. So I thought things we need to learn in terms at the end of this presentation was learn how virtual care or telemedicine is improving access to quality care, disrupting inequities in rural community, and evaluate the gaps that remain. Next slide. So I thought, next slide, I thought we'll look at the role of virtual care in telemedicine, delivery models and benefits of telemedicine, and review some results of some projects in telemedicine and consider future opportunities. Next slide, please. So what are the driving forces in virtual care? My colleagues have said it right. Technology, innovation, And what else? People. What drives technology and innovation is people who are resilient, people who are collaborative, and of course, if you have a crisis, don't cry. Look at the advantages of that, what that crisis will give you, and go for it. Next slide. So, in delivery models, there are many, and COVID has actually brought them into limelight. Teleconsultation, telemonitoring, all sorts of specialties now practice telemedicine. And I can tell you, 15 years ago when I started with Ontario Telemedicine Network, there were very few people practicing or believing that telemedicine was worth dealing with. But today, COVID, in addition to distancing people away, what is done is using virtual care or telemedicine to bring care to your home. Next slide, please. So in terms of delivery model, as my colleagues have said, digital health is helping us with long-term and chronic disease management. It's also helping us in medical education, ensuring that our learners, no matter where they are, can gain access to what you can believe that I have my colleagues and my students in Africa who are joining us in this webinar. And without technology, it would be very difficult, almost impossible. And even with administration, people don't have to travel from long distance to come to urban cities to have meetings for 1 hour, and then they travel for 7 hours. This is what technology and telemedicine or telehealth has brought to us. Next slide. So in terms of medical and surgical practice in a remote area, what are the gains we have? There's timely diagnosis and management, efficient use of healthcare providers, and patients' time. Can you imagine? I work somewhere that's 12 hours away from Toronto. And if a patient has to drive, they will drive close to 7.5 hours to come and see me for a 15-minute consultation. Is it worth the time of that patient? Is it worth the time of me as a practitioner? And this is where telehealth or telemedicine has continued to narrow the gaps and build equities among communities. It has increased access to health services. It reduces anxiety and inconvenience, and definitely reduces costs. Next slide, please. So these are things we see that telehealth, virtual health, call it what you are, is health coming to you, closer to your home, to your advantage. It's cost reduction. We share technology collaboratively, and we can achieve sustainability, growing partnerships and collaboration and team building. Next slide. So, efficiencies and challenges of remote telemonitoring for surgical and interventional is a perceived efficiency that new techniques are taught. No matter where you are, you can be reached. You can reach someone else, you can share your information, you can share your ideas. New equipment are acquired, bringing development from big centers to rural communities. You also minimize and reduce list of capacity building by working together, sharing information. And there's minimal disruption of mentors' time and program because he can do the mentoring from anywhere he is. And the mentees do not need to travel outside their domain of practice. Next slide. So you can see these slides. Telementoring is all many specialties, many possibilities everywhere. Next slide, please. So, but there are challenges. You have to have adequate funding. You got to be creative and think of long-range planning. And there is a cultural mix that builds a lot of disparities. And this is where we need to work. Do we have sustainable programs? What are the politics? Who controls the money? Who controls the power? These are challenges that over the years have continued to plague the healthcare system, not just in America, all over the world. Next slide, please. So I want to share with you just my personal experience in our little community. Over the past 15 years, our studio, 285, has been growing and meeting the needs of rural northeastern Ontario communities. You can see the map of Ontario. The green is in southern Ontario. The yellow is northern Ontario. And in the yellow, you have about 750,000 people, whereas in the green, you have close to 33 million or more, a lot more people there. Next slide. So over the years, since 2006, we have progressed with Ontario Telemedicine Network through a mobile wall unit to desktop. And since 2017, we've been doing the PCVC, where you connect directly to the patient in their homes. You connect to long-term care facilities in their facility. You connect with your colleagues in terms of e-consults, whatever you want to do. You don't have to travel. And with our center, over the past, we've had close to 2,500 virtual care medicine encounters, building and changing the way we practice. And today one can say that telemedicine, virtual care is transforming the doctor's office in time and space. Next slide. So what are the factors that have led to our success? One, you've got to set up achievable goals. You have to have human resources full of champions, adequate funding, right technology, but importantly, continuous quality assessment and evaluation. These are things that are driving telemedicine to building equities, and reducing gaps, and improving the quality of care we provide. Next slide. I'll show you two cases. One is a 68-year-old man. He lives in a village more than 12 hours from Toronto. Community physician, had abdominal pain, ultrasound. They found a mass in the kidney. The pre-op consult was by telemedicine. CT scan was ordered. It confirmed a suspicion of renal cell carcinoma. The gentleman had to drive down to Toronto, had his surgery, and 2 days after surgery was discharged home to a daughter close by. Next slide. And we had 7 days follow-up. He returned, discussed the pathology. He was referred to our collaborative care team. So this case illustrates, builds access, good specialist care, relatives involved in the care, and team approach in total care. Next slide. And at the beginning of COVID, this case, 7:30 a.m. in the morning, 86-year-old man couldn't pee. Went to a community health center. There was only a population of about 500 people living there. The local hospital was 15 kilometers away, not receiving new patients because of the COVID pandemonium. The nearest urologist was 2.5 hours away. by car. And at that time, ambulances were not available. So the nurse had the access to the telemedicine urologist, called the telemedicine urologist, and over the phone, they were guided on what to do. Catheter was inserted, patient was comfortable, patient went back to his home in that community. And the next day, there was a televideo conference between the urologists, the nurses, and that created interprofessional collaborative care, providing a timely access, appropriate care in the home of this elderly gentleman. Next slide. So you see the OTN, which is Ontario Telemedicine Network, is a wide world network for the Ontario people, established by the government of Ontario, looked after for the Ontario people. COVID pandemic has increased the volume of work with the physical distancing, virtual care, and telemedicine is bringing care right to our home and solving a lot of problems, building equity. But still, gaps and inequities remain. There's problem with availability of the internet, affordable housing, affordable income to subscribe to smartphone and data. Governance and policymakers can be quite a challenge, but they are beginning to change with the impact of COVID. More importantly, there's a need for all governments all over the world to consider reimbursement for healthcare professionals as they engage in virtual care to continue to build equities among our communities. Next slide. I think it's coming to an end. I would think that virtual care and telemedicine is a useful tool for building equity in healthcare. It improves access, saves cost. Quality patient-centered care is achievable in rural and remote communities. COVID-19 pandemic has put medicine in the center stage and has pointed out several inequities that need to be addressed worldwide. Thank you very much for your listening, and I do hope that we can learn. My acknowledgement to all the people here, and thank you. Yes, done.
Thank you very much, Dr. Ibarra. Thank you, all dear attendees, for attending to our webinar today. If you have any question, I would be happy to share your question with the panelists and answer your questions. And sorry about the inconvenience and the technology issues that we had in some parts of this webinar. So I would be happy to pick up your questions. If you have any question, please share in the right box that you have. So so if there is a question, please share your question here that I can ask your questions. Sure. One of the attendees is mentioning that in upcoming webinars, that would be great if we navigate more in legal aspect of telemedicine. Sure, we have fortunately we have a pool of experts in our digital transformation leadership group. So we have a plan to provide these parts of the legal aspect of telemedicine in our future webinars, and we'll share with you this part of the expertise that we have in our detailed group. Sure, of course. So all attendees are saying thank you. So if there is no question, so
yes,
I
I have one question, if you allow me. Yes. Well, first of all, congratulations to all of you for this very interesting session. But at the end, we heard from Dr. Anthony about the future and the utilization of artificial intelligence as part of we should say, the digital health, innovation in digital health. So probably artificial intelligence will be part of our routine services in the near future now. And we also heard from Dina, for example, that there are some barriers to the implementation of innovation in health sector. So what do you think that are in fact the major barriers for the dissemination of this new patient-centered health assistant in a broad spectrum? It's up to you to say what do you believe, because I see that also that Dr. Emmanuel presented so interesting results from remote assistance via e-health or telemedicine in Ontario. So what in fact we need to bring these solutions, technological solutions, I should say, innovation in health sector, as we have now the motto, the motivation based on COVID-19. So what really is challenging the widespread utilization of e-health in general?
Thank you, Adolfo. It's a really interesting question, I think. As Emmanuel mentioned, telemedicine, and as previously we've seen, has been there maybe for over 50 years. The biggest issue, I think, is we used to implement e-health, digital health in practice for the sake of implementing it and not really understanding and starting with optimizing existing workflows. The key is, I think, bringing all stakeholders at all levels on board and then thinking of implementing a solution, not the other way around, thinking of a solution and then trying to force implementation into clinicians, into policymakers' hands. So as I'm doing myself for cardiorespiratory health, we're starting co-design processes with the users from the beginning before even having a solution itself. And I think that's where we're heading, having everyone on board from the start to overcome these challenges in implementation. Thank you.
I think I like to support what Tony has said. Communication is key. Engaging the patients is also important. Engaging the frontline workers, as we've seen with COVID, cannot be better emphasized. So collaboration, people bringing ideas together, engineers, physicians, social workers, politicians, we should be sitting on the same table and talking similar languages, probably bringing all the factors together. I think if we do that, working together collaboratively, we'll be reaching the goal of ensuring that we have good access, good quality care, and patient-centered care.
Thank you. We have another question here. One of the attendees is stating that it is interesting to see chronic care is evolving into telemedicine. Where does one find best practices of how each medical specialty are looking at what will become acceptable practices as online non-emergent care, use of tools and aids? How do we get those tools approved quicker across country borders?
What's the question?
The question is about the non-emergent care use of tools and how do we get those tools approved quicker across country borders?
Yeah, that's a very good question, and I think this is why this platform is important, because we are now hearing the challenges of virtual care, and I think it's a global affair, and this is why various nations should be talking to ourselves, because we know there are no boundaries to disease. So the simple answer is that there has to be communication, there has to be active participation of all nations under one umbrella, ensuring that the planetary health is intact and improved and secure.
Yes, actually, as I mentioned earlier in my presentation, one of the most important parts that we need to consider is about building the future-based organization. And this future-based organizations must consider the global-oriented actions and strategies. For instance, in the United States, we have a restrict regulations for the medical devices, for telemedicine services, telemedicine tools. Many countries out there, if they want to bring their products to the United States, they need to pass the FDA. They need to pass many different regulations and standards to get their food into the United States business. For this aim, I do believe that one of the great actions that WHO has stepped down to it is about developing a group of digital health technical advisory group from all over the world. I am one of the part of this group, and they are developing strategies to create comprehensive international programs for the telemedicine services, for digital health technologies. We have the similar regulation for ICDs. We have ICD-10, ICD-11, and many countries are following these ICDs in their countries. If we can integrate this kind of actually codes, this kind of standards in a global level, so we can have a better understanding about each country's regulations and standards, and so we can have an integrated system all over the world.
Yes, probably adding a bit on that is global standards like HL7 is there, and that will certainly help. We certainly, I think the rules have not always kept up with the changing times. I think the world needs to understand that AI-based health system, health apps and the like are global in scope. You can't release it exclusively in a particular country only anymore. We might need to consider mutual agreements like intellectual property, mutual approvals systems, and acceptance that's already taking place also for telehealth. And I think I see a question that how can medical specialties have acceptable practices for online non-emergent care? And for that, what I've seen, at least in my space, which is cardiology, the European Society of Cardiology has started a digital health section. Societies like our International Society for Telemedicine certainly has a role to help develop codes as well. And also primary care societies, and importantly, governments, I think, need to develop their own codes to support that. So specialties, I think, have their own nuances, and they all need to develop their own codes.
Thank you so much. We have another attendee. He expressed her gratitude to all presenters. Thank you so much, especially Dr. Emmanuel Abara. And he stated that I need to use this medium to commend you for the great job you are doing, especially down here in Africa, Nigeria. Thank you, Doctor.
Thank you. Thank you.
The great point that I always comment in our International Society for Telemedicine and Electronic Health is about the diversity that we have from all over the world. And I really love this environment, this atmosphere, which is so energetic, and we can learn about any countries around the world, their knowledge, and this is really exactly part of the knowledge improvement and the part of the mindset change and growth that we have in all over the world. Thank you for ISfTeH to create this opportunity for us to provide this knowledge sharing among our members. Yes, the presentation slides, actually we will share the PDF of the presentations, and also we will have the full presentation in our YouTube channel, so we can you can see all the information and the recorded one over there.
So I just have one message, if you allow me. Okay, first was about this one that you just mentioned about the session that was recorded, and the link will be available on the ISfTeH website in around 48 hours. So those who couldn't attend this live session will be able to watch the slideshow and the presentation. So that's okay. And another one is an announcement about the next webinar to be held on Tuesday next week, is September the 22nd, starting at 3 p.m. local time in Central European Standard Summertime, from the telenursing working group. So the topic will be supporting nurses and other health professionals to choose and evaluate health apps for their patients. So Tuesday at 3 p.m. local time in Paris next week. Thank you very much.
Can I make an announcement too?
For sure.
Yeah, on the 23rd, the ISTEH is collaborating with PAUSA, the Pan-African Urological Surgeons Association, and the theme is discussing virtual care, telemedicine before, during, and after COVID-19. And you all are welcome to attend. It's at 4 p.m. Dakar time, 6 p.m. Brussels, 12 noon Toronto, 11 a.m. New Orleans. And you have faculty from all over the world. So please come along, bring your experiences, and share your knowledge. Next Wednesday, 23rd.
Thank you very much. So if there is no question, so I would appreciate all supports, and thank you so much. Have a marvelous morning, afternoon, or night.
Oh,
Thank
good
you.
night.
Have a great time.
Thank you. Goodbye.
Bye-bye.
Thank you.
Thank you.
Bye-bye.
Bye.
Well done, Dina.